So my name's Becky Kearney, I'm a physiotherapist, and I'm going to lower the tone as I usually do. So Mike Kelly told me to bring my whip along, but I thought it was too early in the morning. But then Matt has handed out a questionnaire entitled Stiff, so maybe it was appropriate, I'm not sure. But I've decided to go with my second passion instead of 50 Shades of Grey, and of Monty Python. So if any of you are not fans of Monty Python, now's your chance to leave the room, because this will be a long 15 minutes otherwise. So, now for something completely different. So I just want to start off by saying I'm not the messiah. I'm an associate professor in trauma and orthopaedic rehabilitation, but that doesn't mean that I know everything. What it means is I'm very good at searching the evidence, reading it, interpreting it, and making my own conclusions based on whether I think it's crap or whether it's any good. And what I can also say is I am a little bit naughty. To be an academic, you have to be. You get told the rules and you learn the rules, and then you figure out how to break them to your own advantage. And that's something that I will talk a little bit about later. So just to give a little bit more structure to this presentation, because all you've been told so far is that it's about rehabilitation, and you've got some physio talking to you at a trauma conference. What is that all about? So I'm going to talk to you about physiotherapy networks and what networks you should know about. I will then tell you how we're already working with you, because you're probably not entirely aware that we are. I will then give some examples of how this has already led to some future developments. And I then want to discuss what you guys want to see next. So I agreed with Mike that I would only present if I was allowed to throw this box around, because I've come to these meetings before, I'm being very envious. So if you don't talk to me, I will just throw this box at you and expect you to say something. So I know this is kind of the third day now for those of you that have been to the trauma trials day as well, so you might be feeling a little bit saturated with information, and I'm saying just a wafer thin mint, we're nearly there, so please don't explode. So, Chartered Society of Physiotherapy. So this is our kind of national body, the equivalent of your British Orthopaedic Association. So according to them, I help restore movement and function when someone's affected by injury, illness or disability. Now, like you guys, you have the BOA and then you have your subspecialties, so I'm studying here in the OTS. As a physiotherapist, I have the Association of Trauma and Orthopaedic Chartered Physiotherapists. And Matt has told me on many occasions that we need a snappier acronym, but that's what it is. And basically we're a group that's interested in both inpatient and outpatient physiotherapy in elective and trauma. There aren't that many physiotherapists, so there's not enough of us to split us up into elective and into trauma. And we have a network of regional networks, so as well as having a committee for our main society, we've kind of set regional hubs as well, which all offer peer support. And we aim to promote research leading to evidence-based publications, and I'm going to show you some examples of that. So they're the two societies that you need to know about. So first of all, the Chartered Society of Physiotherapy, how have we worked with you? Just by show of hands, are all of you familiar with the Getting It Right First Time document? How many of you are aware of it and read it? Okay then, so most of you, so I don't have to explain too much. So basically, this was done by Tim Briggs, and the CSP collaborated with the BOA and included a little bit of a survey on both their elective therapy services in total knee replacements and also on the trauma side in hip fractures. And they basically compared and contrasted and said, so what do we do well and what do we do not so well? And they found, unsurprisingly, that for knee replacements, about 99% of patients got seen on the day of their operation or the day after the operation. They got a 7-day service. They were seen within a week of being discharged. Essentially, they got gold-plated care. When they compared that to a hip fracture population through doing a survey and interviewing physiotherapists, they found significant variation in rehabilitation practice. They found that patients weren't able to access physiotherapy. They were rarely seen on the day of their surgery or the day after their surgery. It was more like day 3 or day 4. And once they're discharged home, they found that only 50% were actually offered physiotherapy. And of those, it was normally 3-4 weeks down the line before they actually saw anybody. So this was quite a damning report for physiotherapists. And then when they interviewed the physiotherapists, they said, we don't have time to deliver physiotherapy. We're too busy dealing with the social care, with the discharge planning and filling in forms. We don't actually have time to see the patients and deliver interventions. And in those services where they did offer 7-day services, quite often the physiotherapists commented that they were still operating with a 5-day service member of staff and just spread out over 7 days. So it wasn't as if they changed anything. So there was a bit of a suggestion there that perhaps we should pull resources that we give to elective patients with total knee replacements to these more vulnerable patients who hadn't planned to come into hospital. So that's how the Chartered Society of Physiotherapy have worked with the BOA, and from this programme of work that they did with Tim Briggs on Getting It Right First Time, there's now some follow-up work to be done, and they are trying to change hip fracture care. So what about the ATOCP, our subspeciality group? So this lovely lady over here is Lucy Sylvester, and Bob might recognise her. She works on the NICE guidelines, so the fracture guidelines that came out. Again, just by show of hands, how many of you read the fracture guidelines by NICE? I hope, less of you. So more of you have read Tim Briggs Getting It Right First Time than the NICE fracture guidelines. That's really interesting. So Lucy, so again, like the OTS, we have a committee and different people have got different roles on there. So Lucy is our NICE representative, and she's a therapy consultant for major trauma at St George's Hospital. And from there were some recommendations made, and I'll talk about how we've put those into action. Something that's going on at the moment, so I'm the research lead on the ATOCP, so I was put forward for this priority setting partnership, which has been chaired by Matt Costa, on fragility fractures in older people, or broken bones in older people, as we've put on the public website. So in all your packs you'll see that you have a little survey like this, and now if you could get these out now, you will see that there is, on page 3, space for 3 questions. Now basically what this is that we have a group of people, myself, Matt and Tim Chester, Xavier Griffin within your OTS Society, we've got an ortho-geriatrician, anaesthetist and some patients, and we've sat together since June last year, having monthly meetings, to design this survey. And this survey got launched 2 days ago at the Trauma Trials Day. And what it's designed to do is capture your 3 top priorities when it comes to research. What are the things you think we should be investigating when it comes to fragility fractures in the lower limb? We've put some pre-text just above those spaces to write in. You'll notice that rehabilitation is on there, and if one of your priorities is not rehabilitation, I'm not letting you walk out this room, so do bear that in mind. And what we want you to do is put the 3 priorities in there, and then where the survey will end in May, we'll then collect the top 10, these will get published, and they will then go on to major funders, and this will be the research that we're funding next. So I know that you all listened to Matt talking about fixed and talking about draft, and you may be sat there thinking, well, I'm not really interested in that, or why didn't they answer this question? So this is your opportunity to feed into the research environment and to say, what is it you want Matt stood up here talking about in the next 5-10 years? But as I say, this is not just about surgery, it's about rehabilitation, about anaesthetic, and about GP practices. So as I say, I'm kind of the physio lead for that, so if you want to ask me any questions, I'd be quite happy to do so. There's also a website as well, so if you want to go away and tell your colleagues about the website, they can fill in the questionnaire online. Oh, sorry, wrong box. So sometimes things get lost in translation. So what I want to reiterate here is that the CSP have worked with the BOA and made some recommendations. We've had our NICE rep on the ATOCP, working with NICE again to develop some recommendations. I'm working with Matt on this priority setting partnership again to make some recommendations. But there's no point in making all these recommendations if we don't do something with them and that we translate everything appropriately. So what have we done? So in regards to the NICE guidelines, there was a recommendation that said currently there's variation in the advice about mobilisation and weight bearing given to people who've had this done. So I've, yes, a nice picture of Xavier. So sorry Xavier, do you not approve? So I've been awarded £1 million from NIHR to do a multi-centre RCT looking at ankle fractures. More specifically looking at whether we should put them in a plastic cast or whether we should put them in a boot. Now my research question is looking at movement, so whether early movement makes any differences, and this is planned to be rolled out amongst all your centres this time next year. So we're just in the planning stages at the moment and finalising the protocol. We plan to recruit approximately 476 patients, and the primary outcome measure was the MOX-FQ, might still be the MOX-FQ. We're arguing about whether it's that or OMAS at the moment, so any comments on that would be useful. So if you are working in a trauma centre and you think you'd be interested in taking part in this study, drop me an email. I presented this at Belfast a few months ago and got a good response there, so we are in the process of planning who our 30 sites are going to be. Now, as I mentioned, NICE kind of recommended that we needed to look at weight bearing as well. From the feasibility work I did for this study, we found, similar to the AIM study, that patients possibly don't follow weight bearing instructions. So just because you tell them to be non-weight bearing doesn't mean that they are non-weight bearing. So actually, is there any point in doing a big £1 million RCT on non-weight bearing versus full weight bearing if patients do whatever the hell they like anyway? I liked Nigel's comment yesterday when he said, I don't believe in non-weight bearing except for calcaneals and Lisfranc fractures. So yeah, there might be some evidence that patients will do whatever it is they want to do. And we've been working with Xavier Griffin. He's got some funding from Arthritis Research UK to run a workshop and an embedded process evaluation within the RCT that I'm running. So it's kind of a trial within a trial. So we're looking at efficient designs and way of saving NIHR money as well. And basically what we're going to look at is it possible to do this weight-bearing RCT, and that's to be discussed on the workshop on Monday. It's coming up. So another thing, so they're getting it right first time, hip fracture stuff. So one of their things was that they said the ward environment is not conducive to rehabilitation of the older person. Patients basically sit around their bedside at meal times and personal care, and this has an effect of increasing dependence and length of stay. And physiotherapists need to focus on getting patients up and moving, but actually this should be the responsibility of all the ward staff, not just physiotherapists. And because mobilisation isn't it's not why I went to university for 3 years to train for. Mobilising patients is something that any member of the ward staff can be trained to do. So obviously all of you are familiar with the white cohort, which is a cohort of hip fracture patients, nationally, which is run by Matt Costa. And within that, he invites people to embed randomised controlled trials. So this is something I'm currently developing with him, because I'm kind of interested in looking at increasing the frequency and intensity of mobilisation strategies. So that there's currently a NICE quality standard that now says patients should be mobilised on the day of their surgery or the day after their surgery. However, NICE was unable to recommend whether the intensity and frequency of mobilisation was cost-effective intervention for patients. So what I'm proposing to do is that we train up healthcare assistants to mobilise patients, and their prime responsibility will be to mobilise patients. So whether increasing intensity and frequency of mobilisation make a difference. So we'd randomise patients to either additional healthcare assistant mobilisation or standard care. Now we're planning to do this as part of a feasibility because, as you can imagine, there might be a few problems along the way. So first step is to get the funding. Second step, a year-long feasibility. And who knows, maybe in a couple of years I'll be stood here saying this is the next multi-centre embedded white trial. So I've put this slide up, it's only a flesh wound. So I think in terms of where we're going next and deciding what things are important, I think what we don't do very well in the trauma setting, certainly in fracture clinic, is what patients need to go on and see physiotherapists, which ones can be self-managed and which ones don't require anything. I just noted down some statements presented at your own conference yesterday. So a lot of comments about do we need to operate on things, should things be managed non-operatively. I put Nigel's comment up there about the non-weight bearing. And Sam made a comment about immediate movement in elderly fixed wrist fractures. Again, wrist fractures is something where we don't actually have very much evidence about physiotherapy or advice or immediate movement or keeping things still. So I was asked to kind of say, what should we be doing? So I think there's some general themes within trauma. So obviously whether you operate or whether you don't operate is quite a big question. Weight bearing seems to be an issue in a lot of injuries. But as we've mentioned, are these trials worth doing and can we do them? there's lots of scope to investigate early movement versus delayed movement, advice versus face-to-face physio, and one-to-one physio versus classes. So this is an example of that is in ankle fractures, again, whether you run foot and ankle classes versus just seeing a physiotherapist. And this is also to do with resource use and cost effectiveness in an NHS that has limited resources. So this isn't the Spanish Inquisition, but I am going to ask you guys, what opportunities are we missing to work more closely together, either within the CSP, within the ATOCP, or whether just with physiotherapists that you know that are interested in working in trauma? What do you think of the current developments? Is what I've told you brand new, or did you know all this stuff already? And what future developments do you want to see? So that's me done. This clock's now saying -3, so I've obviously gone over. So yeah, thank you for listening, and I'm going to start throwing this cube if you don't put your hand up.
Thanks very much, Becky. Any questions or comments?
Oh, a hand.
Totally
I don't have to randomly... No, I'm not a very good thrower, so...
The only reason I'm asking a question is because I'm married to a physio.
All right. Loyalty.
Scared.
Quite right.
I have a real bee in my bonnet about physios, in as far as the physios we have. I think physios are great. The physios we have seem to be incredibly passive.
Yeah.
And we had a scenario with hip fractures where we said we want them up on day one. We can't do that. Why not? Well, we need to get consent from the patient. Half our patients are fucking demented, and they're worrying about getting consent. And I would disagree with some of what you say, in as far as I'm not sure that you were saying, that the care assistants can get the patients up. I feel that the physiotherapists are good at motivating people to do stuff they don't want to do and enabling people to do stuff that they don't think they can do. And I think that isn't emphasised enough in physiotherapy, or certainly in the physiotherapists I work with.
Yeah, and I wouldn't disagree with you. We've had a lot of debates about whether we should do a trial of increased intensity physiotherapy versus normal physiotherapy. But the fact of the matter is that there's only so many physiotherapists, so we aren't training enough, and we've got a growing population of hip fractures. So we need to look beyond physiotherapists, and we need to look into training other members of staff. And this is something that's discussed at our physiotherapy conferences at length at the moment, is that there's not enough of us to deal with the population at the moment.
But a few years ago, there were no physiotherapy jobs at all. And nobody was going into physiotherapy.
There's a difference between not having physiotherapy jobs and the numbers that you need.
Nigel.
Well done, Becky. I think what would be really useful in the physiotherapy world is to have a priority setting program of what is worth looking at and what should you actually forget about. So in the trauma world, there is probably, and you can correct me if I'm wrong, and I like being controversial, there's probably very little evidence that doing physiotherapy for people with wrist fractures is of any benefit.
There's no evidence.
And the same is true for ankle sprains, and quite possibly for people who have post-op ankle fracture.
Yeah.
And we should probably just say, right, we're going to remove all of that, and we'll concentrate on the things where we know physiotherapy is going to make a big difference. And you could turn around using GERF to do it outside trauma and divert resources. So there's no evidence for physiotherapy making any difference in impingement in the shoulder or frozen shoulder.
Yeah.
So just take it away and let's start concentrating on stuff you know you can do.
So I feel that I've got a lifetime's worth of work just doing physiotherapy versus advice or no physiotherapy. Because I agree with you entirely that I think there's a lot of patients that are referred to physiotherapy that perhaps don't need it. The physiotherapists have got long waiting lists, the NHS has only got a finite amount of resources. So I think we need to think carefully, the same way you guys think carefully about what surgical procedures you want to do. You're quite open about the fact that most of what you do is bollocks and it's not shown to work. But you have those discussions and then you do op versus non-op studies. I think as a physiotherapy community, we're slightly behind in that, and we're coming to terms with the idea that perhaps maybe everything we do isn't effective for the patient. But it is an uphill struggle, and trying to get research funded that's saying maybe this doesn't work and has to go through peer review of physiotherapy experts, and so you've got to get that buy-in, so it's very hard.
I think one of the problems that you'll encounter is it's rather like GPs and antibiotic prescription. It's an easy way to terminate an interview. So in a clinic, when you've been seeing somebody for a while and you're getting to the point where this needs to come to, well, why don't you go and see the physio? And it's easy to, and people do. I admit that I do it. I hope I don't do it that often. But you do see that done. And I'm sure that drives a lot of the referral, where people actually know that it's probably not going to do a lot of good, but they think they're doing it to support the patient in some way, which might not be purely mechanical or physiological.
Not doing to passing on a problem that's not going to get better.
And to educate around that would be very difficult, because it's not work with general practitioners and antibiotics where the patient knows it's wrong, the doctor knows it's wrong, it's on the front page of the newspaper, but it still keeps trending in the wrong direction.
Yeah, and that's why I think perhaps rather than looking at physiotherapy versus no physiotherapy, we need to be looking into rephrasing it, kind of active monitoring, advice, self-management, self-support. So I think looking at different care packages is probably the way forward.
Right, final comment from Matt, and then we're going to move on.
Sure, but Becky, I mean, you've done a lot of work supporting us in both research and the clinical side. What can we as the orthopaedic trauma community do to help you to investigate these areas, to see where physio resources, which are limited, are best placed?
I think the biggest thing you guys can do, I think there's a comment there about physiotherapists being passive, and I think that there is a trend within physiotherapists that we rely on the consultants to give us a protocol and then we follow the protocol. And I think empower your staff, empower your therapists, let them know that there's educational opportunities to do MScs, to go on and do PhDs if their appetites take them that way. So just empower them to know that there is support there and that you do support them in challenging ideas and challenging current stereotypes. Because it is a confidence thing. I mean, I stand here, as you are aware, I'm quite confident I don't have a problem in that area. But for a lot of people, it's quite scary going up to their consultant saying, actually, I don't agree with this, and I don't agree with this referral, or I don't agree with this protocol. So encourage them to challenge you and empower them is what I'd say.
Right, thank you very much, Becky. Okay.